I'm very pleased to announce that Dr. Doug Nelson is joining us tonight. He's been a geriatrician. He's board certified family doctor and geriatrician with over 30 years of experience in PALTC. And we were talking earlier this summer, we're looking for the next topic. And I thought that this would be a great topic. He's presented this at the AMDA conference, and he also had an article in Caring from which this is taken. Oh, okay, Dr. White's joining us. So the format for tonight is Dr. Nelson will talk to us for about 20-25 minutes. We have slides, so if you're can look at video. If not, that's fine. And I'm going to hand it over to Dr. Nelson.
Nice to see everybody. Can everybody hear me? If so, kind of wave your nod your heads like great.
Yeah.
All right. I am not a Zoom expert, so the way I worked it out with Christine is that she is going to forward my slides for me. But first, let me say I'm glad to be able to do this. I did give this talk after I was asked to write a newspaper article for Caring and also my workplace. And so most people, I'm 63, so most people in my generation, I don't know what the training is now. I got virtually no training in nursing home work when I was a family practice resident. I spent 4.5 days with my program director, barely paid attention at all because I knew I would never be doing nursing home work. And that was really the extent of my training, and show you how smart I was. Within a year, I was doing nursing home work on the side, and it grew from there. So these are things that I have picked up over the years through hard knocks, sometimes the patient's hard knocks, unfortunately, that I'd like to be able to pass down to many of you. So hopefully you won't make the same mistake I did. So I'm going to jump into this. I got 25 minutes and 22 items, so I think I can do the math. The first 3 slides, that was you had the first one there. This is the second one I'm supposed to tell you about. This is the third one, so hold it there, Christine. So first thing I want to talk about is one of the few things I paid attention to from my program director, Dr. Paul, is that when we started doing it, he said, listen, nursing homes are not like hospitals, where in the hospital, you're the captain of the ship, you run everything as a doctor. And this was a day and age when family doctors were very active in the hospital. He said, nursing homes are not like that at all. You have to realize that. And if you don't do it, it's at your own peril. And I said, if you don't believe me, the fact that these homes are truly run by the nurses. And said, if you don't believe me, then next slide. That's why they call them nursing homes and not doctor homes. So you have to, I had to very quickly become aware of that. Next thing I learned about, and this is true of probably a lot of workplaces, is that I had to be very careful about the relationships when you're in a nursing home like this. And everybody is different, but you have to maintain a professional distance. I hate to say that from the staff. And I've seen many colleagues get in trouble by not doing that. So the one thing I want you to remember is, next slide. And I give you a personal example. When I was 30, I realized, I'd be very careful about joking around with the 30-year-old female nurses. Okay, I got to be careful about that. But I would joke around with some of the guys and also some of the 60-year-old nurses. And then, nobody thought anything about that. Well, I'm 63. I realized I can't be joking around with 60-year-old nurses, and I certainly can't be joking around with 30-year-old nurses. So that's something I had to learn. Keep the slide right there. The next thing that became very instilled in me is that nursing home work is different than hospital work, and it's also different when you take your test in medical school, because when you take your test in medical, there is always a right answer when you take the test, and that's sort of the mentality we're taught. There is always a right answer. There is always the correct solution to whatever problem it is. But the reality is somewhat different. So a doctor that's much smarter than me, doctor of economics actually, has this saying. Next slide. There are no solutions, only trade-offs. And this is especially true in geriatric nursing home work. Many times there is not a solution. There is only a trade-off between other competing things. The other thing that I don't know if you probably, and you may or may not have known this, but scholars have, talked about it for years. Why did the Israelites wander around the desert for 40 years? And finally, I think a number of years ago, they came to the conclusion that the reason that happened is that Moses, like most men, was too proud to ask for directions. Knowing that, I was in that same category. I thought I was too embarrassed to ask the direction questions to everybody, because the assumption was from all the staff is that I had the most important initials behind my name, that obviously I knew everything about the nursing home when I walked in. And it took me a while to realize that I really need to start asking questions when I don't know stuff, and admit that I don't know it. I'll give you one example. Hopefully you people know this through the Futures program, but you may not. But when I first started doing nursing home work, the staff would keep talking about the Medicare patients. And I thought, and I looked around, I said, they're almost all Medicare patients. What are they talking about? And it was 3 years before I finally stumbled upon the fact, because I was too proud to ask, that they meant the people that were in rehab, because Medicare pays them, and that's why they call them that. But that's just one example of I was too. And the next slide, that I need to swallow your pride, ask questions freely. And also as a tag onto that, you will be astonished, at least I was astonished, at how the nursing home staff is more than willing to describe their job to you. They'll be flattered if you ask them. The MDS nurses, for example, I knew nothing about MDS when I got a residency. I never heard the initials until I was in a nursing home for several months, much less knew what they did. And so my assumption is nobody here on this phone call really knows their job as well as they know their job. And you'll learn a lot by just asking them, how do you do your job? Why do you need to do this? And that's true with the CNAs. That's true with the people that run the cleaning service. You'll learn a lot. So please ask questions freely, and you will flatter a lot of people when you do that. Now, the other thing that I used to get really griped about is that, and you'll find this when you're doing nursing home work, there are tons of pieces of paper that you need to sign, or now with electronic medical records, there's more stuff that you'll sign, but you do it electronically. But yet it's like an unrelenting avalanche. It comes at you all the time. And I used to get so griped out about it, because it's just like, when will it end? And then someone taught me the magic phrase. And when they taught me the magic phrase, all of a sudden, all of the upset feelings that I had, all the griping, all of the negative feelings just went away when they taught me this magic phrase. So what's the magic phrase? Next slide. And you know what? When you realize that, it puts all of those signatures in a whole different perspective. At least it did for me. There are lots of pieces of paper and also electronic stuff that only the physician can sign. The APPs can't sign it, the administrator can't sign it, only you can sign this. And that helped me out a lot when I realized that. The other thing that, again, a few times I paid attention to my residency director is he said, when you're in the nursing home, he said, I don't mean to be crass about this, but there are two customers that you need to be aware of. The first customer, we all have been taught that since day one of medical school. The first customer is the patient. Now, the patient is the most important reason why you're there in the nursing home. I think everybody gets that. What I did not get until he told me that is that closely on the heels of customer number one, there is customer number two, which is the nursing home. And you have to be very, very attentive to the nursing home's needs. They have a lot of regulations that they have to follow. There's a lot of things that they need to have signed or have documented. And it's a matter of, they're responsible for keeping the lights on and paying the salaries and keeping the heating working and everything that you really don't think about. So my advice is, next slide, is do not forget customer number two. As doctors, it's easy for us to forget customer number two because we only focus on customer number one. The next thing that I had to learn, and this is somewhat true in the hospital also, is that when I had staff members that weren't doing what I thought would be in the best interest of the patient, or we were having some maybe disagreement on how to do this or how to do that, is I needed to be aware that I was only there to, in a sense, give suggestions, and that fine line you have to traverse when you're in a situation like that, and to realize that you have even though you're the physician there and you're the ones with the best initials, you got to be careful about not crossing boundaries. And I learned this. Next slide. You're not their boss. And so when the certain staff members are doing things, and I think in an incorrect way, and they maybe weren't going to take my suggestion, then what I learned very quickly, and my advice to you is go to the appropriate supervisor, whether it be the administration or whether it be the director of nursing, and discuss it with that person, because they're the boss, not you. And that can hopefully alleviate a lot of angst. The next thing that I realized, and I'll give you a vignette. One of my business partners, a doctor, went to a conference one time. I think it was an AMDA conference, but it was certainly a nursing home conference with for nursing home doctors. And one of the speakers was a lawyer that sues nursing homes. And this lawyer was very upfront and said, we sue nursing homes all the time, and said it's easy to sue nursing homes, the public, because we go in front of a jury trial, or we threaten to go in front of a jury trial, and the jurors are from the general public, and the general public does not like nursing homes. And also the general public's perception is that people that work in a nursing home are just terrible people, and it makes it easy to sue nursing homes. He said, however, we rarely sue a nursing home doctor. Christina, something popped up and invited me to join room.
Oh, no, go ahead. Just ignore.
All right, okay. He said, but we very rarely sue nursing home doctors, because the public perception of the nursing home workers is that they're terrible, like I said, but the public perception of nursing home doctors is that we're angels. And I'll tell you, when I meet people, just randomly, and they ask me what I do, and I say, well, I'm a family doctor, but now I do 100% nursing home work. Universally, they're going, oh, that's great. I'm so glad to have doctors doing the nursing home work. The reality, the lawyer said the general public perceives us doctors as angels doing nursing home work. The reality is, I'm not the angel. I tell you, who the angels are? They're the CNAs. Because they're the ones that will clean you up when you vomited, or when you've had a bowel movement, or urinated. Those are the angels, but the general public does not think of them as angels. So what I have learned is, next slide, compliment often and freely. And I try to, as much as possible, I could always do better, to compliment the CNAs and the nurses, because that might be the only compliment they get all day long. And it's especially true now in COVID. There is a shortage nationwide of CNAs and nurses. And so you may be the only compliment. And, the reality is, a compliment from a doctor is a huge thing. The initials are held in high esteem by, the other personnel in the nursing home. The next thing that I learned, this is actually from a administrator who did not have a medical background. And when she told me this, I'm thinking, number one, why didn't someone tell me this before? And then I thought about it for a while, and I thought, why didn't I think of this myself? So this is what she said. We all know that there is a difficulty with polypharmacy in the nursing homes. So one of the things that you can do that will help is that when you're looking at a patient, they're having a problem, and you think, in your best medical judgment, I need to start this medicine, whatever it is. Before you start the medicine, look at all the other medicines and try to at least think about this. Next slide. And you'll be surprised how often you'll come up with two medicines and go, yeah, they probably don't need to be on that anymore. So rather than just add in another medicine, even though maybe the correct medicine to add. And I wish kick myself, but for years I should have thought of that and didn't have, rather than a non-medical administrator, tell me that. So the other thing is that it is important that, there is and there's, again, the saying doesn't have as much now because of all the electronic medical records, but in my day and age, everything was done by paper. And so I had a professor one time ask a group of us, and this is when, again, when I was in medical school, CAT scans were coming out, MRIs were on the horizon. There was, there were new instruments coming out all the time. And this doctor asked us, students, and said, what is the most expensive medical instrument? And we're going like, I don't know, CAT scan, and we're throwing up all these various technical things that we thought about, radiation therapy, this and that. No. The most expensive medical instrument is the doctor's pen. That's the most expensive because there you can order all sorts of stuff, and so that has an impact in the nursing home. And so remember I was saying earlier about the nursing homes kept talking about the Medicare patients. I did not realize, hopefully all you do, but maybe there's some that don't, that when the patient is on rehab, the first, up to 100 days, but on average 20, that everything that you order, every test you order comes out of their profit right there, out of their bottom line. So be very careful about, do you order this test? And also, do I need to order it now, or can I wait until it doesn't come right out of the nursing home's bottom line? And I don't want to go into all of the various iterations of that, but the important thing is when you're in the nursing home is this. Next slide. Learn how the money flows. It's not always logical, but it doesn't matter that it's not logical. Learn it, and you will be a much better medical doctor as a result of that. The other thing that, and this is true, I think in life in general, but certainly within the realms of medicine, is that there would be times when I would scratch my head and I say, why is this, person doing this administrator or this director of nursing or somebody that owns a chain or something like that? And I couldn't figure out why. I mean, usually you can figure out somebody's motive. Maybe they're selfish. Maybe they're trying to be kind. Maybe it's a religious thing. Maybe it's moral. Maybe they're lazy. Good and bad reasons why someone does what they do. Usually you can kind of figure it out. But there's always a group of decisions that people do that I would just scratch my head and I couldn't figure it out. And then finally someone smarter than me said, when you are confronted with a group of decisions, you don't know, why the person is doing it, this is usually the answer. Next slide. It's always about the money. It's never not about the money. So if you can't figure it out, that's usually the answer. The other thing that no one taught me in residency is about the yearly survey. I knew they had it. I knew it was big. I knew it was, people kind of start scrambling around that week. But what I did not realize is that these administrators and directors of nursing, live in fear many times of the yearly survey because they've all had colleagues that have lost their job based on the yearly survey. And I've been doing this for 30 years, and there's multiple administrators and director of nursing in that category. Sometimes it's justified. Sometimes they're the sacrificial lamb, but it is rough. And so during the yearly survey, one of the things that I always do is the survey team will come into a nursing home, and what they'll do is they'll camp out in some, conference room or something like that. When I go in go in these facilities, try to every week, and I walk in, I find out that it's the survey. I will go immediately to the surveyors, introduce myself, tell them do you have any questions? And if they don't, I say, well, the nursing staff can get a hold of me if you have any questions. And many times you can prevent a nursing home from getting a big penalty by being available and also being smart about what you say. And if you think that the nursing home is not doing something that they should be doing, be very careful about, that is generally not the best time to throw a nursing home under the bus. That's a discussion for another day. But it is a huge deal for the nursing home people. And also a lot of the surveyors, and this is hard to say, but their personalities are sometimes can be a little difficult. And when you think about it, what if you had a job where you go in 5 days a week and every day you go into your workplace, everyone there despises the fact that you're there? That's got to wear on you. And these people do it year after year, and they know that the people there do not like them. They don't want them there. And every smile that they see from a staff member of the nursing home is probably a fake smile. So just be aware of that. It would wear on me. And so that's what you're faced with when you're dealing with a lot of the surveyors. Next thing that I learned when I was just starting out, I would get a patient that I knew is not going to be lasting long. They're directly admitted from the hospital. I would sit down with the family members, and as nice as a bedside manner I could muster, tell them that grandmother is just not going to do well. We're going to try to keep her comfortable, but I wanted your expectations to be in line. And usually the families understood that, but there was always this group of families that would just get angry, and I couldn't figure it out. And finally it dawned on me, this is what, from a layman's viewpoint, this is what's happened. Grandma's been in the hospital for a couple of weeks. All of these smart doctors in the hospital have seen grandma. And from a public's perception is the smart doctors are the ones in the hospital, and the ones that are lazy or not smart or both are the ones that do nursing home work. Even though I'm an angel, I'm probably not very bright. That's the layman's perception. And so I realized that what was happening is, from the family standpoint, is all of these smart doctors saw grandma. None of them mentioned that grandma's not going to get over this. And I'm the first person to mention that grandma's probably not going to be cooking Thanksgiving dinner next year. And they would get mad at me because they thought, well, I must be lazy or I must not be very bright, because that was true. Surely one of those bright doctors in the hospital would have mentioned this. So what I did learn from someone smarter than me, from all families, but it really helps with the families that are struggling with this, is ask this one question to the families. So the next slide. And that a lot of times, not always, but a lot of times will help the family members kind of get things in perspective and come to the realization, okay, well, my goal is that grandma will cook Thanksgiving dinner this next time, but I guess that's probably not going to happen. So that is a good question to remember. The other thing to remember is when you've done everything, you've seen the patient, you've done your orders, you've decided what you're going to do, and then at some point you have to get and record this in a progress note of some sort. And that's always just like a grudging task. You have to do it. There's no way around it. But don't get upset about the fact that you're having to do all of these, click there and click there like that. I mean, well, you're going to get upset, but to try to put it in perspective, Medicare, when they're looking at your progress note, they don't care how good of a doctor you are. What they care about is that you're, filling up the note in the way that they think is the appropriate way to fill up a note. And so the reality is you have to fill up your note with, next slide, accurate yet useless information. That's just the way it is. We can't change it. And so, just roll with it, but that's what you have to do. The next thing is, if you can, when you're looking at your career, and I'm assuming most of the people in the Futures program have not yet signed up for a job. Maybe some of you have, but if you can, and again, there's a lot of factors, try to find a job that is like this. Next slide. The best medical groups, this is what I've learned through my years, are physician-led and business person-run. I've seen groups that are physician-led and physician-run. And, maybe you could do that when I first started out in medicine and the regulations were a lot simpler and I actually did run my own business. I can't anymore. You need a business person to run the group, even a small group. I've also been a part of groups that were business person led and business person run. and they don't understand medicine as well as they think they understand medicine. So if you can find a job that is led by physicians but run by business people. The other thing is, no one ever told me this in residency. When I started getting recommendations from the pharmacist, I thought the pharmacist was trying to tell me how to do my job. And some of my colleagues I found out were reacting the same way. And literally no one ever told me that the pharmacists are required by federal regulation to make these recommendations based on certain algorithms. And the nursing home is required to have a pharmacist that will come in and make these recommendations. Now, as the doctor, you don't have to follow the recommendation, but you do have to give them a good reason why you're not following the recommendation. And when you really look at it, most of the time their recommendations are actually pretty good. But no one ever told me that this is something that the pharmacist had to do. So next slide. Because they will a lot of times find stuff that drops through the cracks. The other thing, and the few times that I did pay attention to my residency director, he and I were seeing the patient that going in a room together, and there was this poor, demented woman there who had end-stage Alzheimer's, was cachectic, laying in a bed, and she just looked pathetic. And we've all seen those type of patients if you've been in the nursing home. And he said to me, he said, when you have these type of patients, be very careful, because we've been trained in medicine to cure. That is what we've been from day one in medical school. You do cure, 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 cure. You're in the nursing home. That is not always generally the case. But sadly, this is what happens a lot to our patients. Next slide. He said, in medicine, too often we flail people with technology. So when you're thinking about ordering a test or some kind of, something with technology, refer back to that question I said that I advise you to ask, family members, ask it of yourself. What is your goal? Because many times technology is not, the answer to your goal. Other thing that I would advise you to do is if you're doing nursing home work, is seek out other people that are doing nursing home work, because it can be sometimes a lonely job. Even though you're there with people all day long, you're the only doctor there, and it can be isolating at times. So next slide. Hang out with other nursing home doctors more often than you probably are doing, and you have to make a conscious effort to do that. The other thing is, and this is true if you were doing hospital work or even in a business, this next one is I need for you to be very careful about getting involved with gossip. Because next slide. Gossip can be a black hole and respect the gravitational pull. And that's probably true in any work site. And I've seen, unfortunately, it's been just a few of my employees, whether it be doctors or APPs, but when it happens, it's not pretty, and it can really cause a lot of problems. Next thing, I'm going back to surveyors. It turns out, and I did not realize this, that's what I'm telling you, is that the surveyors cannot override your medical decision and penalize the nursing home. So this is as actually my colleague, it happened to him. So about 20 years ago, it became pretty established that diabetic diets for patients in the nursing home actually cause more harm than good. Now, if you're 30 years old, a diabetic diet, and you're diabetic, a diabetic diet is a good thing. But if you're in a nursing home, it actually increases mortality and morbidity. And this was pretty established about 20 years ago. So he was at a nursing home, and this new surveyor who was a dietitian by trade, was just got her job as a surveyor, and she was hot to trot and going to set the world on fire, and cited the nursing home because none of the patients that were diabetic had a diabetic diet. Well, what happens is that the nursing home has the right to appeal the decision. And in most states, certainly in North Carolina where I'm at, you go to the appeal, And the survey team is there, which is usually about 4 or 5 members. And then they have another surveyor team, which acts as judge and jury, which I don't think that's a good idea, but that's another story. And then the nursing home, presents their case why they think that the decision should be overturned. And so they did their, the nursing home did their spiel, and then the surveyors, reiterated why they thought it was a good idea for them to have a penalty. And so and then it became turn for my colleague to talk, and he looks at the dietitian and he says, diabetic diets are not good for nursing home personnel. It causes an increase in mortality and morbidity. However, toss all that aside. I am the one that signed the order. So all the responsibility is on me. If you're in your best medical, knowledge, if you think that I am providing poor medical care, your answer is not to cite the nursing home and penalize them. Your job should be, morally, you should report me to the medical board. Are you ready to report me to the medical board? And she kind of slunk down in her seat, and no, she wasn't. And they overturned the decision. So even if the surveyors find out that you're treating high blood pressure with amoxicillin, they cannot cite the nursing home. Now, for that, they really ought to call the medical board. But just to let you know that they cannot do that. The other thing, I'm sorry, go to the next slide. So anyway, they cannot override your medical decision. The other thing is that when surveyors sometimes will talk to you, and they will purposely try to trip you up with the way they rephrase the question. So if they ask you, for example, a yes or no question, and if you give say yes or you give no, it's going to be bad overall, it's just a bad question. You don't necessarily have to answer the question. And this is something I was taught by, again, somebody smarter than me in this situation. Next slide. If you don't like the question they ask, answer the question you wish they had asked you. And that a lot of times can help the nursing home, get out of a possible penalty. And the last thing that I remember from my residency director, Dr. Paul, is in the context of that poor, lady that we had, with the end-stage Alzheimer's, just laying there and very pathetic. He looked at me and he said this, next slide. Old age is God's way of letting us know who's really in charge. And I've never forgotten that. So that is my 22 things. Next slide. In conclusion, ask a lot of questions. Keep learning what it's like to run a nursing home, because you don't know what it's like to run a nursing home. And learning about money, how the money flows, is not taboo. So I didn't time myself. I hope I didn't go over time, but thank you very much for your attention.
Thank you, Dr. Nelson. I'm going to assign the rooms right now to break out, and you will have the opportunity to ask questions. And it looks like we have a very enthusiastic group of leaders. So you will.
Heidi, your microphone's off.
Yeah, thank you, Dr. Nelson. That was wonderful. We just really want to have a time to talk in smaller groups about what resonates with what you said, what resonates, maybe what doesn't resonate, and maybe a few things that people have learned, because most of these people have taken or gotten started. Maybe not, because some people wait a month or two before they get started their new job. They may have run into a few things already that they didn't know, and so we'll get a chance to talk about those things and then pull us back in about 15 minutes.
I think we are.
And so it looks like we had two groups. and so I know what we talked. I'm just wondering if, especially our futures participants, if you have any thoughts that you want to share with about this topic and about your what you're learning and what was discussed in the small groups, I guess.
Hi, this is Sakshi. Yeah, I definitely thought it was very helpful because I started this, 2 years ago in the nursing homes, but I didn't really have a mentor or anybody to ask. I'm just kind of trying to figure things out on my own, just like Dr. Nelson did. So this was very helpful.
Well, Sakshi, now you know you have people to call on.
Yeah.
I hope you'll join us for future sessions that we'll be having with amongst the futures participants. So we're glad you're here today.
Yeah, thank you very much.
And hopefully we'll see you in Tampa.
Yeah.
We're sort of talking about how, like, I was previously in a nursing home where it was much smaller, so I kind of knew everybody. And now I'm in a CCRC and I feel like I don't know anybody, and I don't know how long it's going to take to get to know people. But like I think I've met maybe 15% of the people there right now.
And like
For patients.
Like the leadership, like the staff. Yeah.
And like your reputation is something that is so important. I think this is something I didn't really learn until after I got out of training, that your reputation and what people's impressions of you, especially other leaders, is so important. And so I really liked what Dr. Nelson said about asking questions and being curious, not coming with, why is it this way? But just being curious, why is it this way? Could you just, I'm new at this, I don't understand. And just being inquisitive and acting as if other people have more information than you do is really empowering for them. So.
It's funny, one of my former fellows turned back to me something that they learned that I say a lot, which is help me understand. And I'll just start with, help me understand what happens when the pharmacist, comes in, or help me understand, what this Casper report means, or, or help me understand why this wound dressing was changed 2 days ago when it's, when it was supposed to be twice a day.
I like
Very
that.
well, good way to put it. Yeah, absolutely.
Yeah.
The other thing I would encourage everybody, again, after I did the 22 things, there's also a dozen others I could have added, which I didn't. But one of the things that I encourage everybody, when you go to the nursing home, literally every time you go to your nursing home, make sure you seek out the administrator and you seek out the director of nursing. And even if it's just for 5 seconds, hey, how are things going? And 95% of the time, fine. But 5% of the time, now that you mentioned it, Dr. Nelson, and they'll tell me a problem. And what you'll find out is you will catch problems when they're small, because if you don't do that, then it has a tendency to fester and become big, and then they blast you with it, because it becomes very frustrating for them. So make sure, literally every time you go there, you seek them out. How are you doing? Anything I can help you with? How are things going? And you'll be glad you did that.
Thank you, Dr. Nelson, for spending this time with us today, and thanks everyone for conversations. Sakshi, did you want to say something? You put your camera on. I didn't know if you wanted to say something.
Oh no, I just, everybody else had theirs on, so I did too.
Well, great. I'm really glad to have everyone together. I know that we are. Chris, do you have the next session?
It will be with, I believe, Nikki Brandt, but we don't have a time. It'll be probably in November, maybe even December.
So Nikki Brandt was our clinician of the year this year. She's a pharmacist.
Yes.
And so we're really excited. We had the medical director of the year do the first session, And now we're going to have the Clinician of the Year do the next session. And I know she's going to have some great things to share with us. And, you know, I guess, again, from sort of that interprofessional team point of view. So really looking forward to that. And so I hope many of you will join us.
And tell your friends.
If there are other futures that don't know about this, please let them know. We'd be glad to have other people joining in as well. So
Thank you, Dr. White.
thank you.
And also,
Dr.
if
Simmons,
you'll,
Dr. Bellantoni, Dr. Knowles, Dr. Culberson for just being here and being with the futures participants.
I want to make sure that I indicate also that applications for the 2023 Futures Program is open now. So if you have contact with those who trained behind you, or even those who are working with you who are still new to the long-term care continuum, please encourage them to apply.
Thank you. If anybody has any difficulties, please contact me directly. I'm happy to help. Okay, well, it looks like we're about 2 minutes to the end. Is that everybody good?
I think we're good.
Okay, thank you.
Well,
Have a
bye-bye.
good evening.
Thank you.
Bye.
Bye.